Hey, hello everyone. Welcome. Welcome back. My name is Vivian Lee. I am the president of Verily Health Platforms. Verily is an alphabet company in healthcare. And I am your moderator for today's session. This is the second of 4 sessions of this 2-day event that is hosted by the Roundtable on Population Health. And this is the session where we focus on innovative solutions and approaches to thinking about the costs of population health. And I'm joined by a distinguished panel of 4 who have a rich and complementary set of perspectives, all having engaged vigorously in these areas on the front lines of population health, working closely, whether as a funder, as a payer, as a technology partner, as providers, and certainly across the board, all as thought leaders. Members of the panel today include Rachel Block, who's Program Officer at Milbank Memorial Fund. She's been partnering with states to develop healthcare cost growth benchmarks, and we'll learn a lot more about that. And one of those states was Delaware. Our second panelist, Kara Odom Walker, was formerly the Secretary of Health in Delaware, working closely with Rachel, and we'll hear about that partnership. And now she's the Senior Vice President and Chief Population Health Officer at Nemours Children Health System. Also on our panel today is Ben Mladen. He's the Director of Health at United Way of Greater Cleveland and also Project Director and PI for Accountable Health Communities Project. And then finally, Spencer Caruccio, who's Vice President at Oxyon Venture Studio and former Senior Advisor at CMMI and former Head of Data and Analytics at City Block. So welcome, everybody. It's wonderful to have you. And for those of you who are looking for more background information on our panelists, please do refer to the bios that the organizers have prepared. So for this session, I will start with some opening remarks, and then each of the presenters will start off with a few minutes to share some of their initial thoughts. That these are not intended to be comprehensive, but just to give you a background on some of the work that they've been doing and to get us started on a discussion across these different perspectives. And we're really looking forward to a vigorous discussion, and you have opportunities also to share some of your own questions as part of this meeting. So we're looking forward to that input as well. So let me start by framing the challenge that this group is tasked with discussing. Thank you. So about 12 years ago, the IOM Roundtable on Value Science-Driven Healthcare convened a 4-part workshop. And from that study, they really focused on excess expenditures and the amount of waste and came up with the estimate that I think we are all familiar with, which is that about 30% of all of our national health expenditures in the US were waste. And in 2019 dollars, that worked out to be about $879 billion. Berwick and Hackbarth did another study just not long thereafter, estimated the waste was somewhere between 21 and 47%, which would be in 2019 dollars, somewhere between $803 billion to $1.8 trillion. The Roundtable on Population Health revisited this issue, and there's a really wonderful series of articles and op-eds in the December 2020 issue of the American Journal of Public Health, which I encourage you to take a look at if you haven't already. And in these articles, they're really exploring further wasteful healthcare expenditures and the associated opportunity costs. And here's one of the here's a table from one of those articles by Matthew Spear et al. And it just reviews some of the different estimates for waste, building off of some of those initial pieces of work. And you could just see consistently, while the ranges are wide, pretty consistently showing that the amount of waste is significant. Of course, those of us in healthcare understand it's difficult to quantify, where's the line between effective administration and administrative waste, for example. What is truly preventable? Some of these are difficult, but we know that based on the fact that if other high-income nations can get better outcomes with healthcare for all of their residents at half the cost or even less sometimes per capita, then beyond any other explanatory differences, it's very clear that we are overspending and wasting, and 30 to 50% definitely seems plausible. If we go to the next slide, This article, in turn, then goes through and reviews the breakdown into components and causes of that waste. And you can see that by far, even though the error bars of the ranges are very wide, overuse and missed prevention are at the top. Administrative waste and clinical efficiencies are next, and then excessive prices, fraud, and abuse follow thereafter. And in the context of what we'll be talking about in terms of opportunity cost, I think it is really, I just want to double down on the opportunities around missed prevention, because there we just see so much potential direct benefit from our efforts to reduce waste and translating that directly into better health and better health outcomes. So in this session, we want to explore lessons, I guess, how we can drive down the cost of care, lessons that we've learned at the federal, state, and local levels. And we'll discuss questions that think about just why this seems like such an intractable problem. Questions like, what levers do we have? Who needs to be engaged, especially who isn't sufficiently engaged now? What tools do we have to identify waste and reduce it? What are the roles and responsibilities of payers, clinicians across the landscape, suppliers like medical device manufacturers, pharmaceutical companies, patients, communities, social services? What are the roles and responsibilities of each of these groups? And then I think a very, very challenging question, which the roundtable and the series of articles also put forward, which is how can we leverage the savings that might be recovered from these efforts and really effectively direct them where there's greatest need? Now, when I think about this question, I think about immediately a personal experience that I had back in 2012 when I was told that as of January 1, 2013, Utah's state Medicaid program was going to become completely capitated. Now, at that point, I was the CEO of the University of Utah's healthcare system, and we cared for about a fourth of the state's Medicaid population. And all of a sudden, that woman who had been in our emergency room 52 times in the previous year, when we had billed the state 52 times, was now not only going to be our responsibility as a patient, but she was going to be our responsibility financially, almost a liability, if you will. And here the state implemented, I think, a very effective means of forcing us to think about cost and incentivizing us to drive down waste. And it was really, really hard. We had really no tools. First, we didn't even have the analytics tools to know who these individuals were, how much they had been coming to the system in terms of how much they would be costing us. We just billed all the time. We were not really attentive to the costs of care. We didn't know who was overutilizing, who might have been a prevention opportunity, where we might have had administrative waste, or maybe we're deviating from clinical pathways, or creating other clinical inefficiencies. We didn't know any of those. But you can definitely bet that we started thinking a lot about it, and we started trying to work on figuring it out. And for example, one of the areas that we became most concerned about with this new payment model was the NICU and premature babies, because we could see those costs pretty evidently. And so talk about a prevention opportunity, implementing good prenatal care and preventing one bad outcome. I don't need to explain to this audience the significant cost savings and avoidance of suffering that implies. And so we implemented a vigorous program around prenatal care, which was really effective. And we also did other things. We assigned patients to PCPs. We worked on getting medications to people. We started partnering a lot more with community programs around housing, transportation, food services. And overall, at the end of the day, we did okay from a health system perspective. We did okay financially and in terms of outcomes. But I learned a lot of key lessons. I learned that we didn't have the tools. We didn't really have the culture, although we grew it. That better outcomes definitely lead to lower costs of care. And so focusing on quality, both in terms of adoption of best practices like prenatal care and improving safety, were really good areas to focus on. That more investments in public health and social determinants of health to lower the cost of care overall, but maybe it's best not to rely on hospitals to try to provide those services, that a partnership model would be better. And I also learned that even if you can do all this and you can actually save money and cut out some of the waste and deliver better care, the savings don't necessarily go to those who need it. That by placing hospitals at risk, if hospitals do well, then they're the ones who recover those savings. So these are just a few lessons, just a few reflections from my own perspective, and I'm really looking forward to the opportunity to hear our presenters speak and then to have a really, really great discussion. So with that, I'd like to turn the podium over to Rachel Block, the program officer at Milbank, and give her a chance to share with us some of her perspectives as a funder and partner with states and entities across the country. So turning it over to you, Rachel.
Thank you so much, Vivian. I'd like to thank the members of the Roundtable and the staff at the National Academy for organizing this session. I hope all of you are familiar with the Milbank Memorial Fund, but we work to improve population health by connecting leaders with the best available evidence and experience. And this combination, connecting leaders with evidence and experience, is very much at the heart of the initiatives that we have been implementing relating to healthcare cost growth benchmarks. I'm going to give you a brief overview of why we chose this as an important initiative for the fund. And then, as Vivian indicated, you'll hear from our next speaker about specifically how one state has actually implemented this regime. Next slide, please. So I think that the Roundtable quite adequately covered this ground, but just briefly, when we talk about this, we do like to show the statistics. First, how is health spending contributing to the overall percent of GDP? We know that that has grown. If you go to the next slide, you will see that in many respects, health spending has been going up, but other categories of spending have been going down. And so the conundrum that we face is that we have an increasing amount of our economy being devoted to healthcare spending, but it seems that it is crowding out spending in other important areas. How can state leaders balance the needs that they have across their entire state? Vivian just gave us a great example from a health system perspective. We'll be talking about this a little bit more globally at a state level. If you go to the next slide. So we start with, I'm sure many of you have used this to begin discussions about healthcare. You can't improve what you can't measure. And so our starting point was to try to understand how could we develop a better understanding and a common understanding of what are the factors that are contributing to healthcare cost growth, how that compares to growth of the economy and household incomes, and also how this relates to the financial health of states overall. And so the idea that we would try to capture overall healthcare spending measures seems like a simple starting point. And we are working on this across all payers, including Medicare, Medicaid, and employer-based coverage, and then looking at how to set a statewide healthcare cost growth target or benchmark. I'd just like to say from here on out, each of the states is using this terminology in their own way, but target and benchmark for our purposes are pretty synonymous. The concept here is that instead of the state just looking at their own spending, which is pretty much how they have looked at it in the past, that we really are looking at spending for the entire healthcare system at the state level, and then trying to drill down into broad market segments, into individual components of healthcare systems, and then ultimately to individual health payers and providers. Next slide. Massachusetts is the first state that implemented a healthcare cost growth target. And they did this starting actually over 8 years ago. And I'd just like to preface this by saying that the reason that Massachusetts embarked on this strategy was because they had already done one important thing, was to try to expand healthcare coverage to almost their entire population. And as a result, they took care of one policy priority, which was to cover almost everyone. But then they recognized that they had to address the next important healthcare priority, which was to make sure that that system would be affordable, and that it would be affordable for the state, and that it would be affordable for all of the participants in that system. So they passed legislation to set this target. They also set up the Health Policy Commission, which was a new agency that is broadly responsible for evaluating factors that are driving healthcare cost growth in Massachusetts. Again, looking at spending from a global perspective. Now, as you can see, as we look at where the benchmark is set, and that's the dotted line that goes pretty much straight across in the middle of the slide, and then drops down to the 3.1%, which is where they are today. And then you'll see the blue line, which is the actual rate of spending that they were able to calculate. And part of the story here is that we have to have a system that is flexible enough to take into account unexpected things. One of the biggest factors that led to that big bump was the introduction of Sovaldi. That was an unpredictable event. COVID was an unpredictable event. Well, some would argue it was predictable, but not at this level, right? So by setting a target, it does not mean that we have a hard cap on healthcare spending, but rather that we are monitoring how healthcare spending growth actually ties to whatever that target or benchmark rate the state selects. Next slide, please. And as you can see, Massachusetts has been successful so far in terms of keeping their healthcare spending down relative to the rest of the country. This is not the overall healthcare spend, but the rates of commercial spending nationally and in Massachusetts. Now you can see that there are some general trends that Massachusetts followed, but in general, for recent years, they have stayed under that. And so some have asked, how much did the target contribute to their ability to do that? And that's part of what we are seeking to understand as we implement Milbank's initiative going forward. Next slide, please. So starting with Massachusetts, we had two other states that decided this sounded like a very plausible way to try to get our hands around overall rates of healthcare spending and begin to introduce a common discussion for how we could address the factors that would be driving healthcare cost growth. And so we started with Massachusetts, Rhode Island and Delaware followed, and then most recently, Connecticut and Oregon, through executive orders and through legislation, respectively, decided to move down that road. And once that became the case, Milbank decided it was time. We had enough evidence and enough building experience to bring more state leaders together to implement a healthcare cost target strategy. And so the new program, which we are advancing right now, will allow us to provide technical assistance to additional states that choose to follow this path. And in this slide, you'll see others that have committed to setting these targets that we'll be working with. And in addition to these, we have at least two states, California and Pennsylvania, that have currently pending legislation, and they may be going forward with these efforts starting this year. Next slide. So what is our program? We were fortunate to team up with the Peterson Center on Healthcare, who jointly agreed that helping states to focus on total healthcare spending and the factors driving healthcare cost growth made sense to them. We are providing technical assistance to 5 states, Connecticut, Nevada, New Jersey, Oregon, and Washington, over a 2-year period. And we will be assisting them to develop these healthcare spending targets. And as I said earlier, it includes medical expenses for all payers, but it also includes other important factors, including those costs that are being borne directly by patients. And that will be an important factor of the analysis going forward. Next slide, please. So what are the key steps that the state leaders will be following? Each state will be adapting this overall framework based on their own starting point and how they work with their stakeholders. But these are the basic components that we asked each of the states to commit to. And the first was to convene a stakeholder group to provide input to the state. This can't be a unilateral thing that the state comes along to set its own policies. It has to be done in conjunction with key stakeholders who understand all of the different variables that are involved. Another factor that they will be looking at is to determine what kinds of spending should be measured. And here we face an interesting challenge as we're coming to understand more clearly. For those states that have claims data, that's not easy to do, but it's available. What we don't know as much about is what's going on in the non-claims part of healthcare spending. And so part of the learning experience through this project will shed more light on how we can address that. Each state will be developing their cost growth target methodology, which basically means setting what are the specific indicators they'll choose for their benchmark. They'll be determining which parts of their healthcare system will be assessed in terms of their performance against that benchmark, and using that to determine how data will be collected. They'll be developing their data analytic capacity to monitor and to publicly report this experience, and to analyze the performance against the benchmark to develop a data strategy that will identify the biggest cost drivers. And finally, last but not least, the states will be developing policy responses that are basically informed by the activities, and particularly the cost driver analysis that they will be conducting. So in summary, what we hope to be capturing through this experience is the key concept of transparency. How do we evaluate total healthcare spending and those components of healthcare spending across the system? We will be looking at what are the factors that drive healthcare costs. They will be different in each state in terms of their significance. We will be assisting states to choose appropriate policy solutions that will address those cost drivers. And finally, if the states select to go in this direction, they will be determining how to hold the system accountable for what happens as those cost growth targets are set. So hopefully that is a good way to set the stage for the next speaker, who will talk about Delaware's experience in following this program.
Thank you so much, Rachel. I'm looking forward to sharing a bit about our journey in Delaware. I am now with Nemours Children's Health System. However, I think the reflection of the work that we did in Delaware is critically important. And now I'm on this journey from a different perspective, but certainly as Secretary of Health and Social Services, we had to follow these approaches. Next slide. So Delaware started out, like many, thinking about this transformation, this move to value, this idea that we wanted a healthcare system that supported patient-centered care. We were a CMMI SIM state and had ongoing conversation about how we were going to accelerate the move to value with data-driven initiatives that were based on community principles, engaging those populations that needed it most. Next slide. The conversation that emerged from that was that we were truly unique in that we spend more on healthcare than most other states in the nation. We were only behind Massachusetts and Alaska, and we're looking often to Massachusetts experiences, and I'll talk more about that. But we also had the opportunity to elevate health, in that our overall health ranking was low, and wanted to really accelerate the movement to paying for health. We also saw the trajectory of the state's budget and its impact on growing healthcare costs. And I think more than any other compelling conversation I had with stakeholders or legislators, it was about the dollar going into healthcare that was growing faster than the state's revenue and pushing out other important investments that the state wanted to make in infrastructure, education, state salaries, for example. Next slide. So I think this slide I actually borrowed from Massachusetts, where they just showed this graph, and I just recolored the Delaware bar and made the same exact argument that they had made in Massachusetts, that our state spending per capita was just out of line with what it could be. And it was very hard to look at other data points and sources that were available and explain why we were number 3. And certainly I tried and made many cases around why this unique environment was situated exactly where it was. But I think above all, it just said we had an opportunity. Next slide. It also went in parallel with this conversation that when you start to look at the projections, and all this was based on CMS publicly available data, so I pulled it, looked at the projections based on healthcare costs and growth, they terrified many people around what it would do to the state's revenue, to budget targets. It certainly got the governor's attention around what we could do around realigning our healthcare costs and priorities. And oh, by the way, in 2017, when I arrived as Secretary of Health, we also had a major budget deficit. So pairing it with this conversation that was contextual and personal and based on where we saw the need was very helpful to bring together stakeholders to solve a common problem. Next slide. We also started to look at increases in categories of state spending. So when you looked at these bars that compared 2013 to 2017 year-over-year spending, you saw pretty stable growth in things like salaries, infrastructure, public safety, and we saw some marginal increase in public education due to increased enrollment, which was it resonated with people. It made sense. But then when you looked at healthcare, it was easy to call attention to that increase, and it truly said to our legislators, we needed to figure something out. Our revenues were not keeping pace, and how do we reprioritize along the lines that we really want to start focusing in on investing in our youth and our communities. Next slide. So we went through that approach that Rachel just described. We started to have these public dialogues and had 6 summits where we brought in speakers from across the country to talk about ways that we could refocus on value, ways that we could focus on health and really realign some of those costs. But we also brought in almost every summit we had, someone from Massachusetts came or from other states who had tried to take on this challenge. We then had enough buy-in from legislators that House Joint Resolution 7 went forward, created an advisory council where we also had a balanced conversation from different stakeholder point of views around what the parameters for a spending and quality benchmark could be. And for Delaware, it was very important that we tied these 2 conversations together, not only around costs, but also how we created a healthier population. Then the governor took those recommendations from this advisory council conversation and created executive order number 25. Now, unlike some states that used this process to create legislation, ours ended up being an executive order. We could talk about that in the dialogue later, but it did establish a framework and process for the quality benchmarks and for reviewing the annual target, healthcare cost target that we wanted to review in an ongoing way. So in 2018, we had the first spending benchmark set at 3.8%. There's an annual process that's built into the state budgeting mechanisms and an advisory council to review that annually, make sure that what's set out in the executive order doesn't need adjustment. And then every year we'll have this ongoing public, transparent conversation around whether the target was met or not, and the same with the quality measures. Next slide. I think it's important to know that this benchmark can vary depending on where you are. Ours looks similar to Massachusetts, but it's a little bit different and specific to the concerns that our stakeholders brought to the table. It is equal to the potential gross state product, and it accounts for a long-term outlook in healthcare spending. It takes into account these changes that can happen in the population, like Delaware, inflation, labor force. And then it also built in a bit of a flexible process to, a fudge factor, if you will, to allow everyone to adjust to a healthcare cost benchmark. And so you can see laid out in the slide from 2019 to 23, there are targets set that ideally, 3% would be in line with the state's revenue, but we eased into it. Next slide. So this is the equation. And again, every part of this methodology was discussed in an open forum. We allowed for public comment and people to send us written comments, letters, speak in a public forum, and talk about why these adjustments were necessary to the projected gross state product. And thanks to David Cutler, who often guided those conversations around economic modeling and additions in a very thoughtful, open, easy to understand way. I will forever be grateful to him. But I think it was also important to have measures that were pulled from publicly available data sources, so anyone could calculate this on an ongoing basis. I can do this, tomorrow and try to figure out where it would be, and it's not a surprise where these numbers are getting pulled from. Next slide. We also set up the healthcare quality benchmarks. And again, for a state like Delaware that wanted to have these conversations around, well, yes, maybe we're spending a lot, but maybe we're getting something for that money. We've had these intense conversations around what measures could guide us to better health. And they fell in these three key areas. One was around an indicator of access to primary care, ambulatory care, sensitive conditions that are specific to emergency department visits. The second was 2 measures around the opioid crisis, which has hit Delaware pretty hard. And the third was a suite of measures around cardiovascular disease prevention and treatment, which there are several indicators that suggest that Delaware has momentum to build into prevention and treatment for cardiovascular disease. Next slide. So I think that these categories are important, and we will have open dialogue around adult obesity and high school students who are physically active, opioid-related overdose deaths, and tobacco use, which are population measures, things that the healthcare system can influence or can directly improve, and then healthcare measures, which we are still working on the opioid-related measure that looks at how we're measuring co-prescribing for benzos and opioids, but also emergency department utilization, persistence of a beta blocker treatment after heart attack, and statin therapy. And those measures will be broken out by payer, by location of care, by population at large. Next slide. So this is where we are, and I left the state in July, and so we were just getting started with this process where we had collected data and had the first conversation about what the baseline would be. And this is what the baseline represented, that total healthcare expenditures were about $7.8 billion, about $8,000 per Delawarean. You can see the breakdown by payer. And I think this allowed us to say, now we're not just relying on data from CMS, which has some challenges. There are a lot of imputed missingness that we had to account for and other sources of data, but this is our data that we collected directly from the payers and now can share in an open way. It is a baseline, so you can't use it to compare to other things, but I think it gave us a great starting point. Next slide. You could also see this breakdown by category around hospital spending, physician spending, pharmacy spending, and the amount that was explicitly pulled out from rebates and other claims. I think, again, it's very helpful to have this conversation, but what will be more important is the year-over-year comparison to see what the growth is in these categories and what the growth is in total year-over-year. Next slide. So the collection of the initial preliminary benchmark spending data was very important. We learned a lot. The preliminary data showed that we still had a lot to learn, how to work with the payers to make sure that their data was submitted in a consistent way, that we could interpret it in the right way. And so there's a lot of technical assistance that goes out in order to do this directly with the payers and directly with those who are interested in the results. And so we actually are recollecting, when I say we, I still mean Delaware, we are collecting the calendar year 2018 data as part of this process so that we have better year-over-year comparisons. And then additional analyses will be performed at the insurer and the provider level if there's adequate size. But again, you can't compare this to other sources of data. It is its own entity and its own analysis. Next slide. I think that what's important for the journey to value is that the benchmark, especially by executive order, is a target, it's a goal, and it's a conversation point for us to allow other conversations to come in. And so the journey that Delaware was on included these other mechanisms to move to value, and to move to the conversation we're having throughout the roundtable meeting today, where we're talking about moving to improved health for a lower cost. But they include things like using this benchmark as a guideline for state employee benefit design, looking at other levers that are in existence at CMMI around global hospital budgeting, around pediatric ACO models, around how do you use this for your managed care contracts and embed some of these targets in other places. It also helped the state design and release a request for information around creating a Medicaid ACO and adult dental coverage, all which we knew would lead to better cost overall. And it also allowed a momentum around healthcare costs to allow for a 1332 waiver process around reinsurance and affordability, which again, that affordability really resonated with many in the state, many consumers and many who are trying to navigate the healthcare space. I think it also helped stimulate a separate conversation around investing in primary care, and that target around avoidable use, around emergency department use, allowed us to also have a second streamline and policy conversation around how do you create a legislative process through transparency measures, through measuring primary care spend. And so this movement, and each state has its own side conversation that happens, this interesting dialogue back and forth with stakeholders, but we are all learning together, and I think it has been helpful to have other states in this journey with us. Next slide, please. So I'm happy to share those experiences. There are lots of war wounds along the way, but we certainly have information posted about the summits, about our technical documentation that may be helpful for others as you're thinking about whether to pick up a benchmark or other cost and quality initiatives. Thank you so much. I look forward to the conversation later. And now I'll turn it over to Ben.
Great, thanks, Kara. Well, I'm glad I'm going third and not first, because I think it's a great transition from what Kara and what Rachel have talked about. The initiatives that they've worked on, the attention to overall health spend and how out of control health spending is, especially when we're not seeming to get value for that spend, has created fertile soil for the kinds of initiatives that I was interested in as a community practitioner on the ground, including the collaborative approach to public good investment, or CapG project that I'll be talking about today. So hoping to give an on-the-ground perspective to complement some of the higher level theorizing that Kara and Rachel have shared. So next slide, please. So United Way of Greater Cleveland, we like raising money for social services, right? We've been doing that for over 100 years. Denver says they were the first United Way, but we think we were the first. And so I'm going to say that here. And accountable, one way that we are trying to tackle poverty and build up the social service sector was through the Accountable Health Communities Project. Many of you have probably heard of this, but this is a model test through the Center for Medicare and Medicaid Services. We are one of 29 bridge organizations across the country, lead organizations across the country, working on the Accountable Health Communities Project. We are one of only 2 social service providers, so we're a pretty atypical grantee for CMS. And as part of this project, they've asked us to convene an advisory board that would identify gaps in social services and make an effort to fill those gaps, working together with hospitals, managed care, policy wonks, academia, service recipients, social service providers, the whole gamut. There are obviously lots of gaps out there, easy to find those gaps, but few new opportunities to address them when it comes to meeting people's social needs. We also know that the US, thanks to research from somebody I'm about to talk about, that the US underinvests in social services compared to other rich countries. And then we wonder why our health outcomes are worse. That we don't know for sure that there's causality, but multiple studies have shown, depending on how you define social services, that our spend is less. That doesn't necessarily mean that it's too little, but I think there is this idea that we spend this ungodly amount on social services for very little value in this country. And it's interesting, I think, for a lot of people to see that our spending is generally a bit lower to considerably lower, depending on how you do the research. Another thing, thanks to folks like Kara, folks like Rachel, health providers and health insurance are getting into more value-based, risk-based kind of arrangements. There's a lot of look at spend. There's a lot of pressure to bring down the cost of care and improve quality. And so hospitals and managed care should, in theory, be incentivized to address upstream chronic disease issues around chronic disease management, particularly social need, particularly meeting people's housing needs, food needs, utility assistance, personal safety issues, transportation needs, workforce needs, all kinds of possible social needs that could, down the road, positively affect someone's health outcomes. But the health sector, by and large, continues to pay most part for downstream reactive treatment after someone's already sick. Next slide. Next slide, please. So as part of our advisory board work, we, at our first meeting, brought in the person who, with one other person, literally wrote the book on this issue of possible underspend in social services, now Dr. Lauren Taylor, who, unbeknownst to me when we booked her, was working on this new model for funding social services that positively meet social need and positively affect health outcomes, with Dr. Lynn Nichols out of George Mason University. That was the CapG model. Next slide, please. So CapG's basic theory, it's a funding mechanism for facilitating upstream investments on social service projects, aligning with insurance and provider financial incentives that especially come out of the desire to have more value, more risk-based payments, more of a look at spend and how to reduce that. The theory, the big insight here is that by investing collaboratively, we can remove some concerns about free riders and wrong pockets and incentivize investment. It has been our experience at United Way. Well, no doubt there are many benefits to a competitive marketplace. When it comes to doing upstream investment, when it comes to changing systems, we find that working collaboratively is more effective. And we wanted to bring that sense to the CapG model. It seemed like a great fit for us. I share my own anecdote. There was one decade in my life where I had somewhere between 8 and 10 insurers. I lost count at some point. But what incentive did those insurers have to invest upstream in me? A year later, I'm going to be with someone else. And then not only do they not see a return on that investment, they've given a quote unquote free ride to a competitor and helped the competitor get ahead of them without having to pay for it. So investing collaboratively takes away some of this free rider issue because if everyone, all the hospitals, all the plans are investing in the same service, then whoever's bouncing around from provider to provider, from member to member, is probably all going to even out. And there will be less concern about that. There will be more safety in investing upstream. A thing that facilitates this upstream collaborative investment is having a trusted broker in the middle, which in the Cleveland area is United Way of Greater Cleveland, which facilitates the investors, as I call them, the health insurance, health providers, and potentially other interested parties. We have a foundation and a area agency on aging in our area who have also invested because they think it's the right thing to do. But they're investing in social services of their choosing through the trusted broker, and I'll go into that role in a minute. Another reason for CapG now is it builds on emerging evidence that social services can save the health sector money. Things like medically tailored meals, which is the intervention we eventually went with here and which we're trying to launch right now. Nurse Family Partnership, Housing First, and there are a bunch of others. The Commonwealth Fund has done a lot of great pooling of those resources, and it seems like there's more and more research on health savings by social services every day. Next slide, please. This is just a quick example of how the theory works. So United Way, in this case, does not come hand in hand to the investors asking for specific dollars to support a social service intervention. Instead, we ask the investors to basically set their prices by giving a bid on what this is worth to them. Should this all work out? Should the social service intervention work out? What would this be worth to you? So in this overly simplified example, the cost here of a hypothetical complex case management program is $180,000. The value expressed, the amount in bids, let's say altogether the insurers giving separate bids for each insurance company, but altogether the insurers bid $110,000, the hospitals bid $50,000, others bid $40,000. That brings us to $200,000. Now, $200,000 is more than $180,000. So great. That means we can move forward with the intervention. And not only that, we can give everyone a discount. So they're not only paying for what they valued, they're paying for a little less than what they valued by giving them a 10% discount off the initial bid that they had. in our, well, I'll go into that later. So that's the basic theory of this, that there's $200,000 of value delivered, but the cost of the intervention was only $180,000 total. And each individual organization can set what it's worth to them. At least in our state, this is more aligned with managed care incentives than it is with hospital incentives. So we expected and did find, while the bids are confidential, I will not be sharing them specifically. I think I can say generally that managed care bids were generally a bit higher than hospital bids, because hospitals are still getting used to the value-based environment. In some ways, if they invest upstream, they could lose money if they don't have the same amount of ICU visits and ED visits. So that confidentiality part allows everyone to feel comfortable investing without having to compare with others or give away trade secrets baked into their bid. Next slide, please. So I know this is the National Academy of Sciences. This isn't necessarily the science part. This is a little more touchy-feely. I am a social worker by training, but I wanted to share some of the roles of the trusted broker that, for bringing organizations together like this, I think are tremendously important. If some of these concepts, if some of these ideas about saving dollars for the system while improving quality are to be realized. So the first trusted broker role is to recruit investors to the general concept of buy-in for collaborative upstream investment. I think it was important to note that we did not start out coming hand in hand for a specific project, but rather looked at the general concept here, which allowed the investors to gradually wade into the water of investing upstream a little bit more slowly rather than committing to a specific project, and allowed them to choose the project in the long run. We had a Shark Tank style presentation where a few different nonprofits presented, and they then chose which nonprofit they wanted to partner with. We facilitated meetings where we set parameters for collaborative investment. For instance, we decided that the first investment should be as quote unquote easy as possible, that we did not want to start something from the ground up. They wanted to invest in something that already existed and just needed additional resources to scale up. They wanted something probably focused on food, probably focused on seniors, and something that would provide as much of a guarantee of financial return on investment as possible. To sell this to their C-suite, the individuals, I was fairly high up individuals, but not C-suite individuals that I was working with, felt that they needed a guaranteed, or as close to guaranteed as possible, financial return on investment. We used our deep knowledge of the social service system to research and seek out projects to fund, and have that meeting where we were able to let them choose, have some skin in the game. We accepted confidential bids, determined if the bids were enough to fund the project, and then set prices right around where the bids were, because we had just enough in bids to go forward. We are now working to ensure the launch of the service through data management and formation of legal agreements that can allow for data sharing. So we have a nice workflow down. We're just waiting to dot some I's and cross some T's around data sharing and legal agreements, and we should be ready to go in the next week or two. And then we want to provide a large-scale evaluation of the project. While we imagine every investor is doing their own analysis of the return on investment for each of their finances, we also want to do a larger scale evaluation, so we have a bigger N, and so we have a real case for doing this in the future. So next slide, please. So in the short term, we're hoping that this year we serve approximately 400 seniors with chronic health conditions, food insecurity, and social isolation, with a program that provides medically tailored home-delivered meals based on research out of Berkowitz et al. And a few others, showing that medically tailored meals specifically targeted to things like renal disease, hypertension, heart disease, and diabetes, as well as weekly calls from volunteers who are trained in helping seniors reduce isolation, particularly in the pandemic, can have a positive effect on health. We hope to have provide a return on investment for the investors and improve the health outcomes of service recipients. But next slide. The long-term outcomes, the ones I think are more interesting for this talk, we hope that a positive experience for the investors, both in terms of how they work with the trusted broker, United Way in this case, as well as hopefully saving money for their systems, will encourage them to want to invest more in larger, riskier, but potentially broader coalitions of projects with CapG as a funding mechanism. There's more potential here to address the wrong pocket problem with the legal system, with municipal government, where we know some social interventions provide savings. If we can also prove savings for health system actors as well, then we can hopefully broaden the scope of the kinds of CapG projects we can do. And thus, we would provide new, much needed funds to the social sector on a sustainable basis. I am pleased to say that the Ohio Department of Medicaid, in a redesign of their Medicaid program, is moving forward with requirements for plans to invest part of their profits into services and to do those collectively into the community and to do that collectively. So I feel like we're riding a wave and really in position to help those plans invest smartly and collaboratively. The last slide, please. So just a couple challenges I want to highlight. Again, this is not necessarily the science part of things, but if we want the science to be applied, I've found that these are issues going forward that we will need to continue to address. Legal issues, particularly around HIPAA, there's still a lot of fear of sharing data with social service providers in partnerships, like Vivian referred to in her opening remarks. Partnerships with social services. Hospitals generally don't want to do social services themselves. They want to partner with experts in the field, but the legal departments want to make sure that the data is secure, and in our case, have required us as a charity to some fairly strict indemnification and other provisions that, should anything go wrong, would be a little scary for us. We're a highly motivated actor. We've put a lot of our organizational strategy into this initiative, but I can imagine that other social service providers, particularly looking at the budgets of some of them, and as a United Way funder, I have looked at a lot of nonprofit budgets. Many of them have very little cash on hand. Many of them have what would be considered poor finances based on the funding structures, based on how they're required to spend most of the funds they have, and would be unable to, should they have a data breach, be able to defend larger organizations like some of the larger hospital systems. They would be, or payers, they would risk going under and may not be able to accept those terms. So I'm not a lawyer. I don't know exactly what the solution there is. I just know that we need to be talking about it more. And then there's the stigma around social services. It has to be said. We had to get over that with some of our investors who were worried that the intervention we're providing is 6 months long. I neglected to mention that. And there was concerns that such a long intervention would promote dependency, in the words of one of the investors, or actually two of the investors now I think about it. So we had to work through the idea that this is based on science, that 6 months is actually less than the research used, that the research on this had more like 19 to 21 month interventions. So that showed savings for the health system and increased quality. So if we're going to follow the research, if we're going to use data, then we need to potentially get over the stigma of giving people things like food and housing and transportation assistance that will provide dependency, that will somehow weaken the will, and focus on the data showing that those things can improve health outcomes and save money. And one last slide just says thank you for the presentation, and happy to take questions about this later. In the meantime, I will pass it over to Spencer.
Thanks, Ben. Well, I think, Ben, you said you were lucky to go third. I feel very lucky to go fourth. I feel like that was, it's such an amazing model. And as we talk about CMMI and our role in setting incentives as a system as a whole, I think those are the types of innovations and models that we really hope to see. And while we think about setting up models and think about the incentive structures we're creating, those types of models are amazing and really a downstream innovation that we hope to see more of. So go to the next slide. So just framing kind of on a top line, I think many of you know, but CMMI's ultimate goal is to change payment design, innovate on models to ultimately improve patient care, lower costs, and better align the system to promote patient-centered practices. I think others have highlighted the challenges greatly. And when we look at, from Vivian, the percent of spend that can be saved through better preventative care or excess services, or we look at the chart from Rachel on the percent of GDP that is going up over time as we look for healthcare spend, I think we all can recognize the challenges that we see. And it really is from CMMI's mandate to think about how incentive design at the CMS level can incentivize better behavior. Next slide. So what I want to walk through are 3 particular models that CMMI has been working on that are really focused on the community. And these models are trying to look at how they can take a little bit of a different way of thinking about attribution, a little bit of a different way of thinking about who is kind of the unit of measure for the model itself, and to look at a community and how can we drive kind of value-based care as a whole within a broader community. Ben spoke about the accountable health community model a little already, but this model, CMMI will provide grants to agencies to implement health social related screening needs for both Medicare and Medicaid beneficiaries in a given community. This isn't constrained to certain providers. It is there to do funding in a certain community. The next model is the CHART model, the Community Health Access and Rural Transformation model, in where CMS will be both providing grants to organizations that will work to implement care redesign in a community, as well as capitated payments, global budgets to hospitals, as well as the additional pathway to create rural-based ACOs. So this is, again, another model where CMS is taking a look at an entire region, a rural region particularly, and trying to use its tools in creating new incentives to drive different care and to drive different innovation. And the last model is the geographic direct contracting model. In this model, CMMI will be taking an entire community and assigning full risk to ACO type entities within that community. This is a bit more towards the global risk side of the incentive spectrum, but enabling organizations to take full risk and therefore think about investments in the community in a different way. Go to the next slide. So CMS has a lot of tools in their toolbox to think about aligning incentives to lower cost, improving quality, and improving alignment between providers and patients. We're going to go through a few of them and particularly relate them to the models we just spoke through. So the main 4 tools that it has in its toolbox are first funding, right, to provide money to organizations to try something different. The second is capitation, right, where CMS will provide a capitated payment to a provider instead of the traditional fee-for-service payments. Then there's risk, right, aligning a provider with the ultimate spending, cost, and quality of a given beneficiary. And the last one is flexibilities, right? The flexibilities to provide care or pay for care that Medicare traditionally hasn't. Go to the next slide. So on the funding side, we talked about the accountable health communities models, where CMS provided grants to agencies to implement screening for both Medicare and Medicaid beneficiaries in the communities. This is ongoing, and current evaluations have shown this has had an impact on lowering ED utilization for the beneficiaries screened. So it's a really encouraging model. The CHART Community Transformation Task will provide funding to lead organizations in rural areas to enable them to go and create local care redesign plans for their given communities in combination with their participant hospitals. So by providing this funding, CMMI is providing that upfront infrastructure and funding for these organizations to go and try and roll out local community change and identifying those areas and flexibilities that will best fit these communities as they think about how they will reform their healthcare systems. And capitation, as we spoke about, is the ability for CMMI to pay providers on more global budgets rather than on a fee-for-service basis. When we look at the CHART Community Transformation Track, CMMI will be providing hospitals with a global budget for both their inpatient and outpatient services. This can enable hospitals in a given rural area to think differently about how they provide their care and better allocate their resources towards keeping people healthier and enable them more flexibility in how they are thinking about their resources. In the GEO model, CMMI will be providing additional flexibilities for any provider to take capitation in the way that this will enable more organizations to invest in population health activities, care management tools, or technologies as they think about delivering their care in a different way. Go to the next slide. So risk is the ability to align the incentives for participant and providers towards the ultimate spending, cost, and quality benchmarks for a given beneficiary. In the chart ACO transformation track, CMMI will be enabling rural ACOs to enter into the MSSP model, but given the unique challenges of rural healthcare, we'll be providing advanced payments to these ACOs so that they can invest in both the technology and processes and people that they need to drive local healthcare change. So in enabling with them both the advanced payments and risk to enable them to invest in really aligning their healthcare system in a different way. In GEO, the CMMI will be selecting direct contracting organizations, and these direct contracting organizations will be aligned full risk for Medicare beneficiaries in the effort to bring an entire region of the community into kind of aligned risk. We hope to see kind of advanced investment in local communities and local things like the CapG model, which once everyone is aligned kind of on total risk, and we really hope to see that increased investment. And the last one is flexibilities. Within each of these models, CMMI is able to provide both waivers and beneficiary engagement incentives to enable these organizations to deliver care in a different way. Both the chart and the GEO models provide a suite of benefit enhancements and beneficiary engagement incentives that enable entities participating in these models to provide vouchers for transportation services or vouchers for meal programs. As these organizations think about delivering care differently, these waivers and engagement incentives allow them the flexibilities to deliver care in these different ways. Next slide. So ultimately, CMMI is running tests, right? These tests are tests of new ways of paying for healthcare. And as we are operating these tests, there are many questions that we're asking when we're looking back and evaluating these models that I think are really useful for the, a panel discussion after this. The main three questions we are asking are first, is it scalable? Right? Some of these models ultimately are being implemented in a few geographic areas or with a few subset of providers. As we think about scaling this model, is it scalable, right? What does the model need to be able to be scaled across the country or in many different communities? What infrastructure, tools, data would it need to be able to scale? Then the next question we need to ask is it generalizable? Right? If a given model succeeds in one community, does that mean it can succeed in another? What were the unique aspects of one community that made it successful that were in another community that would not make it successful? And how do we think about that when we're looking at potentially expanding it or building successor models? And ultimately, does it improve quality and lower cost? Right? There's a baseline question of did it drive savings and did it drive lower quality? But what were the actual interventions within that model that led to improved quality and lower cost? How, when we look at certain subpopulations, did these interventions vary across providers or subpopulations, and did it drive better quality and lower cost for those subpopulations? These are all really important questions that CMMI has to continuously ask as they look towards expanding models or building successor models, given the kind of broad nature of CMMI's mandate to really think about these at a national scale. So thank you all. I'm going to pass it to Vivian.
Okay, thank you so much. This is just really a wonderful set of presentations. I think for those of us who have, or those of you who may be feeling pessimistic about traction in getting cost of care down, I think there's a lot of room for optimism from our speakers and a lot to discuss. We heard from Rachel and Kara about state level initiatives, how Milbank launched with Massachusetts to develop a means of tracking healthcare spending and then set cost growth targets. And then Kara in more detail took us through the Delaware experience that she helped to lead, just how difficult it was to get the buy-in. She made it sound easy, but I think it was, I'm sure, very difficult to get the buy-in, the data collection from all the payers, the setting of the benchmarks, and from both of them, a sense of the success of this effort. And also in terms of, I think Kara shared with us how this setting the cost growth benchmark fit in with other strategies, including quality metrics like substance use or opioid-related deaths, for example, that could drive other initiatives. Ben then took us through the CapG model, looking at investing upstream in social services projects and raised this really provocative question of how to address free riders, the wrong pocket problem, and sharing with us this model about how the different entities can bid based on the value that they see from these social service investments, and the importance of actually having a trusted broker sort of manage the entire process. And then Spencer took a step back at the federal level to describe the three programs we just heard about, Accountable Health Communities, CHART, and the GEO model, and gave us a good framework, I thought, with respect to these four components to think about these initiatives: funding, capabilities that we're trying to build, risk, and then flexibility, recognizing that one size fits all doesn't work at all in healthcare. And that framework then being tested against these questions of are these initiatives going to be scalable and generalizable, and what it really is their overall impact on value. So that really was a fantastic set of presentations. So thank you all very much. In terms of starting off this discussion, I'd like to maybe go back and start with Rachel and Kara, maybe starting off with this question and maybe using the thought that Spencer just left us with, which is scalability and generalizability. With respect to what you've described in terms of cost growth targets, maybe starting with you, Rachel, what is holding back other states from participating in this? Milbank has a limited amount of capability, already taking on so many states. But what's keeping other states back from just going forward on their own, maybe with a lighter degree of support, say from Milbank and others?
Vivian, I'll answer that, but I do want to clarify one thing. We did not help Massachusetts do their work. They created their amazingly elegant design on their own. And we simply wanted to borrow from both their design as well as their experience in implementing that. So I just wanted to set the record straight that they went first and we borrowed from them as opposed to the other way around. But that's part of how I'm going to answer your question. This is, even though we now have the 3 states that went ahead first and now 5 additional states that are moving in this direction, this is all pretty new territory. And so what we generally see when it comes to the spread of state health policy innovation is the states, some of them will be very brave and go out on the frontier to try something new, but a lot of them will wait and see what their colleagues did, how it worked, and then they'll determine if they have the wherewithal, politically and technically, to go forward with a similar activity. So I think part of it is just the arc of how state health policy spread occurs. The second, which will be an issue for all the states that we are working with and all of the states that will follow them, however, comes down to the combination of political will and data capacity. With those two things together, it is quite possible, either at a global level or at a more micro level, to address these issues. The political will starts with that cost curve arc that both Kara and I demonstrated, that if we are going to address all of the spending needs that we have for our economy, for our households, but also within healthcare, as this whole program is designed to demonstrate, if we are going to address population health, we have to do something differently. And the best way to start that is to get everyone on the same page about how to pinpoint where the issues are. That may sound simple, but it requires personal leadership, as I think we would argue, starting with the governor and going from there, but also leadership from across the entire healthcare community. And Kara, I'm sure, will talk about this further. The second area is data capacity. As we know, I'm not going to remember the exact statistic, but only some of the states currently have all payer claims databases. Many do not. Those that have them generally are missing a considerable amount of data, both from self-insured commercial employers, and also this new topic that I introduced, which is the non-fee-for-service or the non-claims component, which is an increasing component of health spending across the country, thanks to the kinds of things that Spencer was just talking about and that many private sector entities have advanced. So there's all payer claims databases are good, but not everybody has them. And those that exist don't necessarily have all the full capability that we need to measure total healthcare spending. So there's a lot of building to do and a lot of goodwill that has to occur in order to facilitate that building. There's more to the story than that, but I'll stop with those two key points and then let Kara fill in some more detail.
Thanks so much, Rachel. I think that's a great place to start. You know, for Delaware, our conversation around healthcare costs started before 2017, before I arrived as secretary. And there were important conversations that were already invested in through CMMI's data innovation model work. And so we had some flexible resources, dollars, already established stakeholder venues to start talking about some of these very challenging issues. And then on top of that, we had a new governor who came in with a budget crisis. So don't let any crisis go to waste. COVID is a good time to bring up healthcare costs again. But we really had to look at the budget in a very difficult, challenging way because of the deficit. So it allowed these conversations to emerge with greater urgency and pace that I think allowed us to really lean into the issue. And the governor knew how important healthcare was. Medicaid is 25% of the state's budget. It allowed us to really bring people together around that. But I will say that the leadership and the political will is huge. I mean, there were major conversations, both in the open and behind closed doors, around disinterest in talking about healthcare costs in an open way. And I think, again, those public convenings and dialogue were a very important part of the messaging. Having communications experts elevate the issue, invest in not only, op-eds and written brochures and media and things that mattered, but really having people who could speak to the issue and the data needs. I will say that in the ongoing conversation that Delaware is having, it's about leadership bandwidth, and Secretary McGarrick was part of this journey, but she is now also trying to figure out COVID response. So I think there's a bandwidth issue for states to start to figure out how to take up this issue in the midst of other healthcare needs when everyone's trying to pivot to address a pandemic, and they're the same people and they are already taxed. And so that is a challenge where I think Milbank has stepped in a perfectly timed situation to uplift those who have some political will, but really need additional bandwidth, technical expertise. For a moment, Delaware saw the data engine and capacity of Massachusetts and said, there's no way we can do this. We have a staff of 3 people. There's just no way we could pull this off. And I think being able to figure out through others who have built up expertise to think about easier ways to address the issues and to collect the data and to make it seamless, because the healthcare claims database in Delaware was not going to be able to address it in the short term. There's a long view. And so I think it's finding states who have that combination of elements that you can bring up, where there's a leader who's passionate, a governor who's supportive, there's stakeholders who are champions, and then also figuring out how to build that gap in bandwidth and capacity in the state can really help other states lean into this.
Yeah, I feel like the Milbank is the expertise and kind of a playbook almost that you're putting together that can help scale this. And one of the things that you talked about, Kara, that I wanted to also ask you a little bit more about was the quality level data. So you talked about, the all payers claims databases, really which are about claims and financial data primarily. But talk a little bit more about I think most of us would agree that better quality leads to lower costs, generally speaking. And so focusing on having that, and also concerns about capping quality, having an impact, capping cost, having an impact on quality, of course, in both respects, having the ability to measure statewide quality metrics. Can can you talk a little bit more about that and how you made the decision to choose the quality measures that you did?
Absolutely. And we had a lot of conversation about the quality measures from healthcare providers, from specialists who wanted to weigh in. And that was a very meaningful conversation about ways to invest in population health. And I would say for a true quality expert audience, these are not the HEDIS measures that you think of. They are a combination of measures that we're both creating as we go, and some that come from population health surveys that are available at a statistical level that we can actually make some assumptions. I mean, high school students who are physically active, as you can imagine, in Delaware is a small number. And so we wanted to make sure the year-over-year change could be measurable in a way that's consistent. So I think we are, on this journey, but where we started the conversation is what measures do we have, can we measure with validity that year-over-year change could be appreciated, and then also that would lead to long-term health or better costs. And so, and then, we presented a list of something like 20 to the governor, and then we iterated and said, which ones are the ones that you care about? And thankfully, again, Governor Carney is very passionate about healthcare and cardiovascular health, and thought that those were issues that really should be elevated and had stakeholder buy-in. But, coming from, I'm a primary care physician, coming from that world, when people talk about obesity measures, some would say, well, that's a really hard quality measure to tackle in a usual primary care setting. I need a lot more resources. I need partnerships with the schools. I need help with, other policies in restaurants and communication platforms.
We need medically tailored meals for like the whole community.
Exactly.
Right. Our whole population needs to think about diet. Yeah.
Exactly. So I think those are areas where we can start to convene, bring people together, bring different stakeholder groups to problem solve. But it's just starting now. So thanks for that question.
I just think it opens up the same kind of challenge of what data do we have, and if you can get the health systems to share the data, but things like tobacco cessation, do we really have accurate means of monitoring these very important measures of overall public health? So really, really interesting. And to that end, I actually was interested in the connection between that and the work that Ben talked about, which is to what degree can the establishment of some of these quality metrics really create an incentive for these social services investments. If there's at the state level, there's going to be some significant, or at the federal level, even Spencer, if there's going to be, if we're going to set some criteria for that is aligned financially and so on around overall population health, is there a way that we can connect those with the kinds of work that you're describing, Ben, in terms of rallying people around to make the right investments in social services to advance those goals?
Absolutely. The work that I've done in this project would never have been possible without an intense statewide focus and national focus, without CMS pressure, inadvertent pressure probably, on the social determinants of health focus and the broader focus on reducing costs and improving quality. So if I had just called them out of the blue and said, "Hey, do you want to spend some money?" it would have been easily rebuffed. But because of these priorities that are out there, because of that focus, and especially I just got lucky, right? I timed it well, where in the middle of talking about this project, we got a new governor, and the new governor appointed a new Medicaid director, and the new Medicaid director wanted to move in a different direction that was more focused on value, that was more focused on social determinants. So that also put some of the onus on these individuals to look at innovative ways to address these projects and help them to incentivize their participation in something like this.
When you were talking about the bidding process, that reminded me of a project that the Commonwealth Fund did. I serve on that board, and there was a project around measuring the return on investment for, say, health systems if they were to invest more in social services. And it was pretty complicated. They brought in some health economists and, created it. I think it's still available on the website, on the Commonwealth Fund website. But I'm curious about how these entities do that calculation. How do they know how much to bid?
We shared certain research with them. This is where having an outside expert was invaluable. Dr. Len Nichols, who was possibly one of the people working on the Commonwealth Fund initiative as well, was there kind of holding my and their hands the first time around anyway, and training United Way up to do this in the future by helping them to think through how they would bid. He created a spreadsheet that had various aspects, like what the expected return is based on what the researchers said the return was in those studies, and other factors that could, as well as asking them to calculate their own risk tolerance. Just because it was done in the Berkowitz studies doesn't mean it's going to work for you necessarily. So there's a certain adjustment that probably they would want to make and did make. So those were all calculations. Only one of them was super open about what went into their calculations at this time anyway. Maybe in the evaluation we can open that up a little bit. But it was interesting to see that managed care was all pretty bunched together, and the hospitals were pretty bunched together around the rates they were looking to pay for this particular service. So those financial factors were fairly similar, and something seemed to be working.
That seemed to relate when I was listening to Spencer talk about the importance of ensuring that entities had the right capabilities. I sort of feel like taking risk and the capabilities kind of go a little bit hand in hand. If you're going to take the risk, then you need to have some capabilities. And one of them, for example, is in understanding where the best investments are for you to get the best population health and to meet the targets that you're expecting. So I'm curious about your thoughts on even some of what we were just speaking about with Ben, in terms of what are the capabilities that you think different entities in the system need to develop in order for us to shift the risk more effectively for population health overall. And I'm particularly interested in from the provider's perspective, and Kara also, I'll ask Kara also to weigh in from wearing her new hat in a provider system, kind of her perspectives about that as well. But maybe you can share some of those thoughts, Spencer.
Yeah, absolutely. And I think the first, as we've talked about a little already, is access to data and is access to information. And when I think about, from Ben's perspective, right, when they're working to think about what is the ROI for this investment, they're unable to do so without data, right? And this is data that, for a hospital system, they need to think about that data in a little bit of a different way, right? It isn't who is entering their walls and who is the services you are kind of providing within that context. It is, for the patients that will be attributed to me, what is going on for those patients in the broader system. And while I think CMS is able to provide claims data, right, that is only one aspect of the system. And I think CMMI has done a lot of work to provide more claims data at a more rapid pace that can more kind of accurately and in a more updated fashion provide insight into populations as they evolve over time, and to enable providers to really have a better nuanced understanding of what risk means and the interventions that they should or shouldn't take for those populations. But I think then organizations have to think about how are they going to leverage both maybe the clinical data that they are already capturing as part of their care today, and how do they merge that with claims data to really provide that longitudinal record that they can then use for that deeper understanding. And then on the social needs side, how can you start to collect the information that, say, the Accountable Healthy Communities model was collecting as part of their standard survey tool, right? How do we even think about what is the standardized meaning of food insecurity? And how do I understand that for my population as a whole? Right? This is a massive data collection effort that right now isn't standardized. So I think for providers, as they start to think beyond just, okay, I have claims data, I understand cost. I can start to understand things like readmissions. But when I start to look at what are the cause behind those readmissions, or what are the cause behind high ED utilizers, and they start to look towards clinical data and they start to look towards social data, I think that is where, the ingenuity and innovation will have to continue to push to enable that scalable data collection and that scalable analysis, so that the next time, someone wants to bid in a CapG model, they have a really nuanced view of both what is the ROI for me as an entity, but then what will this mean in terms of my patients, that I think is still early in that evolution.
Yeah, so some of the work when we were first being faced with this idea of taking risk, it was early on in my role in Utah. And I remember being really surprised. I was sort of new to the CEO world. I'd been in academic medicine my whole life, but not kind of at this level. And I was just so surprised at how little we knew about the things that we were about to jump into to take risk for. We knew almost nothing about our cost of care at the individual episodes of care. We knew overall we spent this much on labor or this much on pharmacy, but in terms of, for every patient with, pneumonia, or for every pregnancy, just what were we spending and what were the variations, and just simply having some of those tools was absolutely essential. Having the data. It's exactly what you're saying. And if we didn't have the data, the right data in the right people's hands, the CFO might have all the data in the world. But in this particular case, if the providers didn't have the data, there really wasn't much hope of us being able to manage costs, because that's where most of the decisions were being made. Yeah. And I wonder a little bit, Kara, about now your perspectives on these cost growth targets, on managing costs, and on driving to quality metrics now from within Nemours system, from within the vantage point of a healthcare system.
Yeah, I think it is unique to be in a children's health system when Medicaid is a primary payer, and trying to figure out where the Medicaid population seeks care, and not just medical care, right? But all of the other social services that we've been talking about. So we are on a journey. We are in multiple states and have multiple sites. So we have a hospital in Delaware and one in Florida, and those dynamics are very different between those two Medicaid programs, but we certainly are leaning into it, trying to move to value. We have a launch of a Medicaid ACO that is an exciting way to accelerate some of this movement to value and use it as a starting point for branching out. So we're doing social determinants of health screeners, trying to connect the dots in creative ways to community resources. But I think that the need is around data. Even at the state level, I couldn't tell you the families who access services from 3 or more state agencies because the data did not yet talk to one another. I couldn't tell you how many Medicaid children also receive SNAP benefits because our data just did not talk to one another, and it was expensive to invest in that data connection. So I think we have a lot more work to do to make sure we're able to not just talk about social determinants, but to overcome them and make sure we're connecting the dots, as Ben is doing so creatively around housing and health and home visiting, but well beyond our walls in the hospital. And I think that's our challenge, but also the opportunity right now at Nemours.
Mm. And do you feel that Nemours, as a system that you do have the right mix of capabilities as an organization, you mentioned some of the data, but beyond the data, do you think you have the other capabilities that are going to be necessary? It's just sort of how are you looking at that horizon?
Yeah, I think that Nemours is investing in it. We're building in it. We have data expertise, we have capabilities, but all of this requires partnerships. So we need data feeds from the payers. We need assistance from the state, and none of it is in a silo. And having those connections and partnerships and collaborations are critically important. I think Spencer just said it. The hospital doesn't own all of the data, and so we think we have the experts, but now we need to sign 50 legal documents to make sure it flows to us and then produce it in a way that's digestible. We want to create kind of equity dashboards and track those measures, but we don't have perfect data yet there either. And I think that is part of our learning opportunity to make sure that we're moving to value as quickly as possible. But I am thankful. I think that what is unique about Nemours is that we have the hospital leadership buying into the idea that it's important and we have to move it forward, because I think we could be our own worst enemy if not, where we just say, well, we're not going to do it until someone forces us to. I think what we're seeing is this is this is important. It's momentum. We can take better care of all of Delaware's kids by creating a Medicaid ACO. And now we just have to figure out what those barriers are, how we overcome them, how we bring in the state and other partners at the community level to do a better job.
Well, they're really,
if I may,
yeah, please go ahead.
The more capabilities that will need to be built are in the social service sector too, as much as hospitals like CARES are building up their data capacities. The social service sector has long been neglected in terms of its ability to build up infrastructure such as that, and figuring out these simple things like unit costs, figuring out what the cost of their service is for the hospital, how much it will ultimately save the hospital. Those are capabilities that I suspect will also need to be built in partnership with some of the health sector entities in a way that's collaborative and helps everyone involved at some point.
I think that's a really great point. One of the questions I was going to ask you was about whether I had the privilege of doing some research for this book that I wrote called The Long Fix. And one of the people I interviewed and got to spend a lot of time with was Mandy Cohen. And she was telling me about the work that they were doing in North Carolina, bringing together all of the disparate data sources, but really primarily focused on, social determinants and the need to kind of have one data set. And that's what you've just said was exactly kind of the question that I was going to ask you, which is how do you view, what would be the optimal kind of way in which United Way could, and organizations like yours could partner with state entities to kind of build the right data systems and build the right resources together? Because there's no point in each of you trying to kind of do things separately, right? And what are your thoughts about that?
Thank you for the question. I think there's tremendous opportunity for a central convening organization like a United Way or a Health Collaborative or some other such organization to be in the center of some of these transactions and to help build the sector's capacity so that each hospital is not trying to contract and figure out this data piece with a million different social service organizations. But if there was one central place to do that, that would be helpful. We've sort of taken that model with CapG rather than having the individual investors all communicate directly with the social service provider, the Benjamin Rose Institute on Aging. They're bringing it through us first, and then we're sending it on to Benjamin Rose. And while that's a little less efficient for this one pilot project, we're hoping to build a model where the data can flow through us for multiple projects like this and allow us to then compare and contrast what's going on, allow us to identify areas where the social service sector could grow and gain capabilities. We also think we could play a role and are just beginning planning stages on helping local organizations to build capacities to partner with entities like managed care and hospitals. So there could be a role in the center for an organization like ours to bring everyone together, find out what everyone needs, spec out what needs to happen, and then start to build that capacity.
Well, one could argue, and I'm looking at Rachel and Spencer here, one could argue that we should just build some big databases and that it should either happen at the state level or it should happen at the federal level. I kind of would love to hear a little bit of a debate or a pros and cons, and that we just make that investment once and for all. We've just set aside $1.9 trillion to invest in lots of things, including infrastructure. What would be Rachel, can you maybe share your views, and Spencer, your views? Why not just have a big federal database and get all of this stuff all coordinated and just get it all done at once? Or state by state, is that the better way? Rachel, go ahead.
Well, I don't know that there is a single right answer to this question, but I'll share at least a few thoughts about why states are the right place to organize this. And the first really comes down to who's going to use the data and what are they going to use it for. And clearly the federal government would have great uses for some sort of big national database, but healthcare is not delivered nationally, at least yet. And so while we still have this highly decentralized system, it seems to me you need to build data capabilities that will be most relevant and accessible to that decentralized system. So I would not argue that doing it through states is the ideal situation on paper, But given the considerations about how healthcare is delivered, how it's paid for, and who ultimately are making the kinds of decisions that we're talking about here, they're closer to the ground level than they would be for a national database. I think there's probably also some technical considerations in terms of doing all of this at a national level. But just to go back to my one point about one of the great limitations of the current state data capabilities is the ability to get that self-insured data. The No Surprises Act took two important steps that are helpful to states. One is the federal government has never funded APCDs, and so the act will provide for the first time federal funding for APCDs in a robust way. So that opens up some new possibilities. The second is, while it did not take the ultimate step, which I think many states would have preferred, to require self-insured plans to submit their data to state APCDs, it is creating a process by which employer needs to utilize this data will be addressed, and hopefully it will inspire more self-insured employers to submit their data voluntarily to these APCDs. It would fill a huge gap in what currently exists. As I said, this is not the perfect solution. There are good arguments for a national approach as well. But I think there are some practical considerations for why, at least for the foreseeable future, building this capacity at the state level makes sense.
Spencer, what do you think?
Yeah, I mean, I think I agree in thinking about how healthcare is delivered today and where the best knowledge about how to combine all of that data at that level is really currently sitting at the states. Right? Each state has their unique setup for their Medicaid program. Each state has their unique kind of makeup, and I think I could really understand about how to think about that state being the best kind of and most near use case for that data. When I think at the federal level, I think what the power of the federal government can be in this, and you kind of hearkened at it a little bit right then, is the ability to set standards and the ability to set requirements so that in those, this may be state-driven initiatives, that there is standardization across state payer databases, right? I think when we look at the ONC rules around data formats, say moving to FHIR or payer-to-payer exchange, those are extremely powerful standards when we think about the ability to scale data collection, right? And I think we've started to see the government push on those more and more. And I think those will really pay off in the long term, because even if like the implementation lives at a state or local level, right, if the data can have the same form, it enables us to more rapidly iterate, roll it up to the federal level or states to talk to each other in ways that wouldn't be possible without standards. So I think that's a really powerful area for the federal government to continue to push on, right, is on standards, is on thinking about standards for SDOH data. Right? There are projects like the Gravity Project that are thinking about what does that data look like in a standard format. I think those are areas that the federal government has a unique ability to set, and that has a unique ability to really help our system scale in that way. So I think that there's a good balance between what the states can think about and their understanding of local delivery and local delivery on that scale, and the ability for the federal government to really think on that long-term path and how to really set up the system so that it can evolve and scale.
Thank you for that. There are some questions in the Q&A, so encourage people to give. One of them is going to be about seniors, and I do want to address some of these questions that are coming up. But before that, I just would love to hear, Spencer, your reaction to Ben's point about, I having to worry about indemnification and the risk of data and all of that, which is another standards, interoperability. There are many barriers to us being able to share data, but I think that's actually a really important consideration, which is kind of the monetization of data, and then all the things that kind of the consequences of that create all these legal issues and other ownership issues and so on and so forth. Do you have any reflections to share on that? You had been the head of data and analytics at CityBlock, which was very much about bringing in all kinds of data sets. And then, of course, your role at CMI, you've been thinking about this a lot in Oxion.
Yeah, absolutely. And I think it's a really interesting evolution as we move more and more to value-based care, because we are asking and incentivizing people to share in the care for beneficiaries in a way that they haven't before. And when we think about traditional care, right, there's covered entity for the purposes of treatment. And there's a pretty logical step of, okay, you go to this person, you go to the next person, we're going to share a record. And HIPAA clearly outlines all of the frameworks of when you're allowed to do that and when you're like those disclosure bases. I think there is starting to think about what does data sharing need to look like in a real value-based care environment, when we are asking people to really come together and say we're going to jointly use information to manage a population, right? Rather than managing a patient who might be directly in front of me, rather than managing in this very treatment-focused way, we are looking at a population. We're looking at public health and medical health and really combining it. And therefore, that requires us to use data and information in a different way. I think the Office of Civil Rights has looked a little bit and has, I think, written out some things around what does HIPAA mean in value-based care, and I think is exploring and thinking about what those evolutions might look like. So I am hopeful as a person who has used data and as a person who's combined data from a lot of entities, that as we both think about what we want care to look like and how do we want providers to evolve in the system, that we continue to look at, what does regulation look like? Both what does data regulation look like? What does it look like from a Stark and anti-kickback framework when we start to think about how providers are interacting with each other? I think they're similar to how we think about evolving the system. We need to think about evolving the frameworks we put in place to enable these systems to continue to succeed.
It could be that we might be creating a new wrong pocket problem in terms of who benefits from all these data sets coming together, and how do we make sure that the benefits from that actually accrue to the people who need it the most. I actually think there's going to be an interesting set of developments. So as I said, we have had a number of, I'm just trying to use all the systems here, and there's a series of questions that people have been asking. And one of them is really around, I think these are some of the questions around some of the work that you talked about, Ben, around how does this program ensure that seniors, I'll ask you two of them because they're kind of related. I think, how does this program ensure that seniors are no longer hungry but are healthy, as was the stated goal? And why not include vouchers for housing in addition to transportation and food? Actually, that might have been you, Spencer. So maybe you guys can
Sure. I mean, we are currently building the plane as we fly it when it comes to outcomes. We're going to be partnering with a local data QI collaboration organization called Better Health Partnership in Cleveland to look at some of the quality metrics and some of the outcomes metrics. We initially were laser focused on the financial return on investment because that's what our investors told us they wanted us to focus on. And so they had the dollars, and that was the initial focus because of that. But we do want to know if there's truly an effect on quality. So we will be at least have tentative agreement to look at utilization across the intervention so that we can see, get some sense of how healthy people are based on whether they're using some of the higher needs, more expensive services or not. Lower ED utilization hopefully would be correlated with better outcomes. And we're also going to try to use some of the data that Better Health Partnership also has to see if there's a way to dovetail with what they're already doing to look at quality metrics as well.
But do you have a means, I think this person is asking, do you have a means of knowing that people are no longer hungry?
Well, know that they're no longer hungry. So, some of it is, I think we've alluded to that it's in its infancy. Part of the way that they're determined to be hungry right now is they take a screener that basically says, I'm hungry or I'm food insecure. Okay. It's not any more complex than that. Right. So those screeners would continue to be filled out at visits as more and more people are mandated to, or at least interested in continuing to assess social need within the clinical environment. And a lot of it will be self-report. There is, I believe, a fair amount of research saying that self-report is a valid way of measuring how effective something has been, how effective an intervention has been with the population, that if they say they're doing better, they are. If they say they're not as hungry, they are. So we'll continue to monitor that as well.
Terrific. Terrific. And Spencer, the question about the vouchers for housing in addition to transportation and food?
Sure. Yeah. And I would say, CMMI is continuing to innovate on what the different beneficiary engagement incentives that they can include in part of models. I would say some of the models themselves, like the accountable health communities models, are there to better understand what additional flexibilities they might include down the line. I think CMMI wants to be deliberate in what they test, especially when these often are scaled nationally or kind of at this really large scale, and be deliberate about understanding, what providers are looking for, what types of beneficiary engagement incentives they are able to deploy, what they have the capabilities to do, as we kind of spoke about earlier, as well as then what will really drive that ROI. So I think are areas that are testing under specific models, as well as one I think then will evolve over time.
One of the topics that we haven't talked about much is really individual patient responsibilities or ability to influence cost of care. There's of course been some really interesting work around the fact that if you show people maybe just simply the cost, they may not be drawn to lower cost providers, right? That the general understanding that more is maybe better, higher cost may be better, kind of that the challenges of communicating the idea of value. Sometimes maybe, people who expect the antibiotic no matter what when they go in to see the doctor, for example, and so on. Could you all, I'm interested in your perspectives on the role of the patient and their families in this effort that we're undergoing. Anybody want to take a stab at that?
Thought, which is, it seems to me one of the themes that has run through these presentations so far is the notion that about setting collective goals. And if we build a system based on the assumption that individual choices will change the world, it seems more plausible that committing to collective goals and then enabling all of the participants in the healthcare system to work together to achieve those goals will be more successful. And again, I think that could well be done best at the level that Ben is working, or some of the broader kinds of community efforts that CMMI has sponsored. I think that states have a unique role and responsibility in operating the Medicaid program. They operate under certain legal constraints about what it means for individuals to participate in their healthcare costs. But at the end of the day, if we look at where the costs are going, we talk about wrong pockets, but where the costs are going, households are bearing extraordinary costs for healthcare today. Larry Levitt posted something the other day that the average family premium is somewhere approximately $22,000 a year. That also just happens to be the same figure as a household of 3, the poverty level. So it just shows the magnitude of what these costs translate into at the household or individual level. And it just stands to reason for me that some more collective process of setting a goal and establishing the processes to help achieve that goal would be a more effective approach, trying to take a more coordinated strategy, not just relying on individual decisions.
And certainly not just relying on shifting, increasing risk to the patient. We definitely know that that's not working. So, and any other quick thoughts before we maybe transition to our closing remarks? Spencer?
One I think was really interesting from the CMMI perspective. When we were thinking about how to engage beneficiaries, I think we all look at these models on a pretty regular basis, and they are confusing to us at times about what is an ACO versus what is MSSP versus what is BPCI. As we thought about what it meant for a beneficiary to get a letter that says you are part of an ACO, what does that mean to them, right? What does that mean in how they think about their provider or their care or the benefits they're going to get? As we start layering on more and more models, it even becomes more complicated. So I think what we were really thinking about, and I think we'll have to continue to innovate on, is how do we educate beneficiaries around value-based care, and what does that mean for them? What are we asking them to do? What are we providing them? What does this mean for their relationship to their PCP? And it certainly is an area that feels a little bit underinvested. But if we really want to scale this and we really want to see the benefits, I think beneficiary education needs to be a huge component of it.
Yeah, and I think the words you used also, educating sometimes makes it sound like it's their responsibility to learn, but actually simplifying, the other word that you used, is probably the most important determinant of our success, right? So, this has been a really terrific discussion, and I do want to leave a few minutes for everybody to make a few closing remarks. And I'm sort of provoked by this question from the audience. This person asks, after all these years of experiments around reducing waste, controlling cost, improving value, why do we have so little to show? What has to change? And obviously you've each been thinking about this and you have a lot to show. You have shown a lot, but given this, in the context of this person's question, I think it's fair to say at a national level, take it, looking at all of our numbers in aggregate, we don't have that much to show. So if maybe we'll go in reverse order from the opening comments, and we'll start with Spencer and then Ben and then Kara and then Rachel. But if you had that magic wand, given everything that you know and all the experiences that you've had, what will it take for us to move this dial nationally?
Yeah, it's a great question, and obviously what we've thought a ton about, because I think we have seen really localized and amazing examples of improvement and amazing examples of change. But I think you're right that it hasn't scaled nationally. I think a lot of that is capability building, and capability building, as we talked about, takes a long amount of time and takes a long amount of time and investment in things, as Ben said, that look like public goods at times. And without our ability to build those rails, those public goods that enable organizations that may not have the budgets to invest in a new tech platform and invest in data analytics to look in their ROI, I feel like it'll always feel incremental, right? It'll always feel that we are getting one organization at a time to shift, rather than we are seeing kind of large scale jumps in what we'd hope to see in innovation. So I hope that, through investment of maybe the federal government or local organizations that are really doing these innovations and this investment into what is value-based infrastructure, that with enough of it, with enough data exchange platforms, with enough ability to share claims data or share referrals to CBOs, that then we'll hopefully see an acceleration in value-based care. Whereas the friction and the lift for a new organization to try to transform their practice won't be as high.
Ben, what do you think?
I would add that change takes time. We have done, I think, a fair amount, but these are complex systems, and building out the prototypes that we're doing now will likely take a while, and then scaling them will likely take a while, and learning lessons will take a while too. On the social service side, the one thing it does appear that the field is learning is that screening and navigation, the other side of the accountable health community shop that Spencer alluded to, but I didn't talk about in my talk that much, that's great. It's probably the first of many steps. Because somebody from the Camden Coalition who was doing screening and navigation before it was cool said after their trial, when they found out that there was no difference between their control group and their experimental group when they were doing screening and navigation, they said they built a beautiful system to navigate people to nowhere. And the next step is doing things like CapG and other pushing other initiatives to truly fund and put resources behind the historically underfunded social services that will potentially bend the cost curve.
I think if I had a magic wand, I would start with a need for leadership to call for this investment in combining the health and social service sectors. We have a wrong pockets issue, and we've talked about that in various environments. And now I'm focused on kids, where the investments made today in infanthood and toddlers pays off in a 10-year time frame, yet every MCO contract is on a 1 to 3 year cycle, where you won't see that ROI in a public good of a invested community health team or a home visiting program to the extent and scale that we need it to reduce disparities or address the cost quality challenge in front of us. And, if I had known COVID was happening, I would have said, let's use this momentum to create a conversion into the system that we want it to be. And I'm not sure it was enough, which is a kind of a concern and maybe even a disgrace that we haven't been able to figure out how to use this conversation about how a pandemic impacted everyone's health because of the social intersection. And so I don't know what it will take, but I think it's going to take a leadership lift and significant investments from other sectors coming together.
I'll just build on what Kara just said. I mentioned that Milbank's focus is on connecting leaders to evidence and experience. I think that historically what we've had is a growing body of evidence, but we haven't necessarily had efforts to connect leaders to the experience of working with that evidence. I'll also just go back to an earlier comment that setting a common goal and then figuring out all of the different avenues necessary to reinforce achieving that goal seems to me something that has been missing from previous efforts. Our model is built on the idea that you have to start with governance and trust. And if everyone comes to the table owning their own definition of the problem and owning their own data, we won't have trust, and we won't have that common commitment to establishing a solution. So starting from a different vantage point, governance and trust drives all of the other things that happen after that.
Very, very nicely put. Very nicely put. Well, I think in these last couple of hours, we have learned a lot